I'm Jennifer Fang, neonatologist at Mayo Clinic and medical director of our Neonatology program. It's an honor to be a part of this year's conference. I'll be presenting on neonatal telemedicine, state-of-the-art healthcare delivery. I do have one disclosure, which is that I have licensed IP and can earn royalties from Teladoc Health, and I also own stock in the company. So I have a few learning objectives for the next 25 minutes or so. I would like to start by really discussing the system level challenges in healthcare delivery that prompted us to develop our teleneonatology program here at Mayo Clinic. And then I'll talk about how telemedicine can be used to improve access to care and facilitate patient triage. And then lastly, I'll describe how telemedicine can improve the quality of high-risk neonatal resuscitation that occur in smaller community hospitals. So first, when we think about development of a telemedicine program, it's really important to understand the gap or the clinical need that you're trying to address with your program. And for our program, for teleneonatology, it was really rooted in the outcome disparity that we see for neonates when they're born in a hospital without an NICU. So I think as neonatal care providers, we recognize the importance of regionalization, that when at all possible, we want our high-risk pregnant women or high-risk neonates to be delivered in a hospital that's prepared to offer the level of care that they need. However, we also recognize that that is not always possible. There may be barriers to that happening, whether they're geographic, economic, or social barriers, or it just may be an unanticipated emergency. And when a baby is born in a hospital without a NICU, particularly our preterm neonates, we know that they're at higher risk for mortality as well as serious morbidity. And I included this map of the United States, which is showing distance to a neonatologist. And those darker, deeper red colors are locations where the neonatologist is in very close proximity. But the lighter and white regions are areas where a neonatologist may be quite remote. So in our country, you can see that in the center and kind of western part of our country, pregnant women or critically ill neonates could be quite a distance from a NICU. And why is this so challenging for our colleagues in smaller community hospitals? Well, in the United States, we have some hospitals that, because of their location, may deliver less than 1,000 or even less than 500 babies in a year. And hospitals are needed in these locations because they serve as a real critical access point to healthcare delivery. However, if you're a healthcare provider in these hospitals, you can imagine that the frequency with which you need to perform an advanced neonatal resuscitation is quite low. And we know that the evidence shows that if you don't use your neonatal resuscitation skills, they decline quite rapidly in a matter of 2 or 3 months. And when you survey providers in rural hospitals, what they'll tell you is that they may only ventilate a neonate 1 to 3 times a year. And we all know the importance of being able to effectively ventilate a neonate, as that's the most critical step in neonatal resuscitation. So if you don't have the opportunity to practice and perform these skills, it can be really quite challenging to both achieve and maintain proficiency as our healthcare system is currently set up. So we asked ourselves, knowing that there's this outcome disparity for neonates simply based on their birth location, is there more that we can do? Again, fundamental to optimal outcomes is regionalization of neonatal care, providers who attend resuscitations, being competent in the knowledge, the skills, the behaviors that are needed for successful neonatal resuscitation. Many hospital teams are including, potentially best practices like briefing, debriefing, and simulation-based training. But again, despite this, we're still seeing the outcome disparity for our patients. So we asked, can we use telemedicine to close that gap? Can we use telemedicine to get the neonatologist who may be many kilometers away to the bedside virtually for these patients in smaller hospitals so they can help guide that care team and provide that additional layer of expertise and experience to really optimize the resuscitation and patient outcomes. So teleneonatology is really that telemedicine network that allows neonatologists to establish a real-time audio-video telemedicine connection so they can be at the bedside of critically ill neonates when needed. And we established our teleneonatology program at Mayo Clinic over 8 years ago. And so far, we've performed over 600 consultations. So Mayo Clinic, the main campus is located in Rochester, Minnesota. And at Mayo Clinic Hospital, we have 2 NICUs. So one is a 34-bed level 4 regional NICU, and we also have a 24-bed level 3 NICU. And it's the 9 neonatologists that staff our NICUs that also provide our telemedicine consults. Now, Rochester, Minnesota is quite a small community, and we only have about 2,500 babies delivered in our hospital each year. But you can see many of our admissions, over half of our admissions, are actually from babies born in other hospitals in our region. So again, it made this idea of using telemedicine very relevant to our practice. Our program in total supports 19 community hospitals. You can see a majority of these, 17 of the hospitals, are part of what's called the Mayo Clinic Health System, which is a network of community hospitals that spans a 2-state region. We also support 2 hospitals that are not a part of Mayo Clinic. And so if you pull all of those hospitals together, we're available to consult on about 7,000 deliveries each year. Now, when we're providing our telemedicine consults, we're generally working in partnership with the pediatrician or the family physician that's at the bedside, as well as other care team members, whether it's nurse, respiratory therapist, or other allied health staff. So what type of care are we providing via telemedicine? So if you look at these indications, obviously they're very familiar and similar to the type of care we're providing in our own NICU. We do a lot of consultation for respiratory distress, whether it's transient tachypnea of the newborn, meconium aspiration, pneumothorax. We also do many consults for prematurity, as well as review physical exam findings, and assist with advanced resuscitations or if a baby comes out and has perinatal depression. So before I move on to really looking at the value telemedicine can provide, I thought it would be helpful to share with you a video of a simulated consultation so you can really get a good idea of the level of collaboration we can achieve through telemedicine.
Mayo Clinic Admission and Transfer Center, this is Chad RN. How can I help you?
Hi Chad, this is Julie. I need an emergency telemedicine consult for a preterm infant going to be born in Austin.
Okay. I just sent the page to our neonatologist, and I need to confirm you're calling from MCHS Austin, right?
Yes.
And briefly, what's happening with the baby?
We have a 28-week infant that will be born soon.
Okay. So, and that's our physician calling here. Let me put you on hold, and I'm going to get us connected, okay?
Okay.
ATC, this is Chad.
Hey, Chad, this is Bill Carey from Neonatology.
Say, I have Austin on the line. They have a 28-weeker that's not been born yet, and they want a teleneo conference. Can I connect you?
Yes, please. Thank you.
Okay. Go ahead, Dr. Carey on the line.
Hey, this is Bill Carey. I'm a neonatologist in Rochester. I understand you have a telemedicine consult for a 28-weeker.
Yes.
Okay, great. Hey, Chad, can you do me a favor and dispatch the neonate team down to Austin, and I'll connect via telemedicine right now.
Okay.
Okay. Thank you. I'm going to stay on the line here until I'm connected, and I'm live on video.
Yes, we have you on video.
Okay, thank you.
Thank you.
Hi, I'm Bill Carey. I'm one of the neonatologists at Mayo Clinic Rochester. Can you introduce yourself so I can understand who's on the team today?
Sure. I'm Dr. Fang, the pediatrician, and I have 2 nurses on my team today.
I'm Julie.
I'm Lindsay.
Great. Good to meet you. I understand you have a 28-week baby on the way.
Yeah, that's right. And we're just getting everything ready. We have our chemical mattress and plastic wrap. We have our Neo wrap set and ready to go. And I have intubation supply should I need it.
That's perfect.
Okay, great. Anything else? Because I think baby's about to deliver.
No, I'm going to tell you, baby.
Okay, all right. Okay, baby's out. Okay, lift baby. Okay, I'll get monitors on. Baby's looking pretty apneic. Is that monitor on here? We're just stimulating.
Looks like you're doing a good job of that. Still apneic.
Yep, still apneic.
Julie, can you check the baby's heart rate for me quickly?
Sure.
And
Heart rate 70.
Okay, it seems like the baby is apneic, so Dr. Fang, if you could please provide some positive pressure ventilation, that would be great.
It looks like, if you could please, tilt the chin back a little bit. Tilt the
Okay.
head back and lift the chin. There you go. That'll help with air entry.
Yep, our manometer is looking much better now. Thank you.
And why don't you breathe a little bit more quickly than you're doing right now? So maybe
Okay.
50 to 60 times a minute.
2, 3,
1
breathe.
minute.
2, 3, breathe. 2, 3, breathe. 2,
How's
3.
the heart rate, Julie?
Heart rate's still 70.
Fine. I'm not seeing very good chest rise right now, so Lindsay, can you
That's
increase the
true.
peak inspiratory pressure up to 25 for me? How does
Okay,
that feel, Dr. Fang?
we're up to peak of 25, and the chest rise looks much better. I don't know if you can see that.
No, I can. It looks
But
good from here. I just wanted to get your take on it.
Yep, it looks much
That's
better.
great. How's the heart rate, Julie?
Heart rate's still 70.
Huh. How are the saturations?
They're 60.
Okay. Lindsay, if you could please dial up the FiO2 to 40%, and we'll see if that helps improve the heart rate.
Okay, we're there. Yeah, and baby looks like baby's doing some breathing on his own.
Okay.
Heart rate's greater than
Saturations now,
100.
Lindsay?
They're at 72.
Okay, so coming up.
Yep,
And spontaneous breathing
it's
looks like it's starting to happen. Kind of intermittent.
it is. It is. Yep, and Julie said our heart rate was greater than 100, so I think baby seems to be responding.
Excellent. Yeah, do you want to try some CPAP alone for right now?
I think
Keep our
so.
attitude where it is? Okay,
Yeah,
great.
let's try that.
Thanks for getting the temperature, Julie.
Oh, you're welcome. It's 37.2.
Perfect.
And
So it
baby's
looks like the
breathing.
baby's breathing pretty well.
Yeah. Yep.
Excellent. Saturations, Lindsay?
80.
That's great. We're moving in the right direction. Heart rate?
Heart rate's still greater than 100.
That's excellent.
And we're almost 3 minutes old, Dr. Carey.
Okay, perfect. So, look, I just got a page from our transport team. They're about 20 minutes out. Maybe one thing to do at this point would be to check a blood sugar, and if you can, place an IV to start some dextrose fluids. Does that seem like a good idea?
Yeah, I think we can do that. Thank you. Baby's still breathing well.
Perfect.
Great.
So I hope the video of a simulated consult really helped to demonstrate the type of partnership we can achieve and how closely we can work with other hospitals via telemedicine. So I want to go ahead and move on to describe how we measure the value that we're providing to our patients via telemedicine. So first and foremost, our program was about achieving more equitable access to care. So this is a map of that Midwest region, and the red numbers are the delivery volumes of some of our community hospitals. And when we think about access to a neonatologist, before we had our telemedicine program in place, less than half of the neonates born in our Mayo Clinic Midwest region had access to a neonatologist. It was only those babies who were born at the Mayo Clinic Hospital in Rochester, Minnesota, where we have our NICU. However, since fully implementing our program now about 5 years ago, we can say that 100% of neonates born in our Mayo Clinic Midwest region have immediate access to an expert in neonatal resuscitation and critical care if needed. So it really helps us achieve delivery of the right level of care to the patient where they're located and when they need it. In addition, as you might imagine, the ability to visualize the baby via telemedicine is also very helpful when you're making decisions about whether or not that patient needs to be transferred to a higher level of care. So it really facilitates very effective patient triage. So what we found with our program is that when we look at all the neonates who receive a teleneonatology consult, about 1 in 3 is able to remain at that birth hospital after the consultation. And if we look at reports from other neonatal telemedicine programs in other organizations in the US, they have similarly found that telemedicine reduces the odds of transport by about 30 to 50%. So I think this is a really important aspect of the program, that through telemedicine, you can avoid the unnecessary separation of mom and baby, that you can avoid the costs associated with unnecessary medical transport and avoid NICU hospital days. And these types of programs really help facilitate bed utilization across a region as well, making sure that when you're bringing a baby to the NICU, you're more confident that that baby does require critical care. So the last value metric that I wanted to share was that of quality. So looking at how does teleneonatology impact the quality of resuscitation. And this was a retrospective cohort study we published a few years back now, where we looked at outborn neonates who were admitted to our NICU. And we compared neonates who received a telemedicine consult to matched controls who did not. So controls that were matched on gestational age, birth weight, admission diagnosis. And then we looked at the overall quality of the resuscitation. So we identified the patients who met criteria for the study, and then we, using data abstracted from the EMR, or our electronic health record, we had 2 neonatologists that were blinded to the intervention review the patient characteristics and resuscitation metrics for each study participant. And then in reviewing that data, they then assigned a resuscitation quality rating on the scale of 1 to 10. Where 1 was a very poor quality resuscitation and 10 was an excellent resuscitation. So if we look at the 92 neonates who were included in this cohort study, the average gestational age was about 35 weeks. You can see 15 to 20% of neonates were less than 29 weeks gestation. On average, they weighed 2,500 grams, though you can see we had some extremely low birth weight infants as well. Not surprisingly, the most common admission diagnosis was prematurity or respiratory distress syndrome, followed by encephalopathy. Now, in this outborn cohort, you can see the rates of antenatal steroid administration were quite low. And I think this just reflects the emergency nature of the delivery, that when these babies are delivering in a smaller community hospital, it's happening quite quickly, which you can see reflected in the high rate of emergency C-sections. So what about the primary study outcome? Well, what we found was that telemedicine did significantly improve the quality of resuscitation for these neonates. When we look at the median quality rating in the telemedicine group, it's 7 compared to 4 in the control group. And the graph on the right is looking at the percent of neonates who had a high quality rating of 5 or greater. And you can see that a significantly higher proportion of neonates had that high quality rating in the telemedicine group when compared to the control group. Now, what was it about neonates in the telemedicine group that may have earned them that higher quality rating? Well, when we looked at all of the discrete data, what we found was that neonates in the telemedicine group were significantly more likely to have many process measures completed. So here you can see that neonates in the telemedicine group were significantly more likely to have their temperature, blood glucose, and blood gas measured. And I think we all recognize the importance of performing these steps, that we know that if a neonate is hypothermic in the delivery room, that's associated with a higher rate of mortality. We need to ensure that our neonates are euglycemic and that we are appropriately ventilating them. So as we think about the value that telemedicine can bring to our patients, I thought it might also be helpful to share with you another short video that's really shares a patient's story and provides the perspective from the provider, from the parents, and from the neonatologist.
On June 30th, 2019, Lizzie Stoltz called her husband Sean to tell him she had just gone into labor, 30 weeks into her second pregnancy.
He said right away, "You're kidding." And I said, no, I'm positive my water just broke.
The couple lives in the small northern Wisconsin town of Bloomer, population roughly 3,500. Lizzie had planned to deliver her second child at the Mayo Clinic Health System Hospital in Eau Claire, about 30 minutes away. However, it soon became clear that wouldn't happen. Her contractions were coming on too strong. So she went to the closest hospital 3 minutes away, Mayo Clinic Health System in Bloomer. The hospital is staffed 24/7, but there's no labor and delivery service or a neonatal intensive care unit. Physician assistant John Farm was working the emergency room and had 5 minutes to prep for Lizzie's arrival.
That's the first thing that crosses my mind, is to assemble the appropriate resources and team to be able to take care of the patients that are coming in. So that's what I did. I called Dr. Score, and then I called the transfer line in Rochester and told them that I'm going to need some telemedicine help as well.
Telemedicine allows medical providers to communicate and see patients from an off-site location through a machine just like this. Dr. Christopher Kalura, a Mayo Clinic neonatologist in Rochester, Minnesota, quickly appeared on the telemedicine machine in Bloomer, ready to assist John.
We have controls in order to zoom in on different areas of the room and improve our audio, talk to providers with a handset if needed. Short of us standing right there with the team, it's the next best thing.
By the time Lizzie arrived at the Bloomer emergency room, she was ready to push. By now, on-call family medicine physician Phil Score had arrived at the hospital. Together, he and Dr. Kalura, over 100 miles away, worked to deliver the baby.
It was literally like having a specialist looking over your shoulder. And there was times where he would pan the camera and have a conversation like, "Hey, what's your name? Okay, we're going to do this is what I want you to do." And yeah, it was remarkable.
The baby was finally delivered, but she was bruised and not crying.
She was very limp and blue and not breathing.
John intubated the 3-pound baby named Madeline Grace. Through it all, Dr. Kalura remained by his side on the telemedicine screen, taking the guesswork out of caring for such a premature newborn. A Mayo Clinic neonatal flight crew then took baby Madeline to Mayo Clinic in Rochester, where she would receive care for the next 44 days. Madeline had become the first baby born at the Bloomer Hospital in years, and the first with the support of Teleneonatology.
It's the patient the right care at the right place at the right time. That's what telemedicine does.
Madeline is now thriving and getting used to life at her real home.
It's broken sleep with a lot of smiles.
Yeah.
That's what it is. She's going to be demanding. She'll be a fighter, that's for sure.
For the Mayo Clinic News Network, I'm Kristen Everett.
So the last thing that I wanted to share with all of you was the results of a study actually we just published that was looking at the perceptions of teleneonatology across 5 NICUs and 27 community hospitals in the United States and Canada. And this was a survey that we sent out to providers at these sites, and we used a validated implementation science measures that really looked at evaluating provider perceptions of the acceptability, appropriateness, and feasibility of teleneonatology. And these 3 measures included a total of 12 statements, and then the respondent rated their level of agreement with each statement on a 1 to 5 scale, where 1 was strongly disagree and 5 was strongly agree. So we sent this out to 365 providers and had a response rate of 56%. So when we look at the results of this study, this was the measure of acceptability. And you can see that this included 4 statements asking if teleneonatology meets their approval, is appealing, and if they like and welcome teleneonatology. And what we found was that the percent agreement with these statements was very high, anywhere from 88 to 98%. And you can see the mean score also very high, 4.5 to 4.7 on that 1 to 5 scale. Now, what about the measure of appropriateness? So these 4 statements were asking providers' perceptions on whether teleneonatology seemed fitting for their practice, if it was suitable, acceptable, or seemed like a good match. And what we found was that appropriateness was again rated very high, that the percent agreement was anywhere from 93 to 97%, with mean scores 4.6 to 4.7. Now, the last measure was one of feasibility, where providers responded to statements asking about implementation, if teleneonatology seemed possible, doable, and easy to use. And again, we found the percent of agreement was very high, anywhere from 88 to 99% of providers agreed with these statements, with mean scores of 4.4 to 4.6. So I think what this study shows is really a broad receptiveness to teleneonatology for both providers in NICUs that would provide the teleneonatology consultation, as well as providers in smaller community hospitals where they would receive the teleneonatology consultation. Now, when we looked at these ratings across different provider roles, years of experience in neonatal care, or previous telemedicine experience, there was no significant difference between those groups. And there was no difference between NICU providers and community hospital providers. What we did find was a small but significant difference between providers and community hospitals with a level 1 well newborn nursery versus a level 2 special care nursery, where providers in that level 1 nursery rated teleneonatology significantly higher across these 12 measures. So in conclusion, I hope I was able to share how there were system-level challenges to healthcare delivery for neonates requiring resuscitation or critical care that really drove us to develop our teleneonatology program. That telemedicine can be used to improve access to resuscitation expertise, facilitate patient triage, and really improve the quality of these resuscitations. And now what we're learning is that newborn providers in both NICUs and community hospitals perceive teleneonatology to be acceptable, appropriate, and feasible for their practice. So I would just like to close acknowledging my amazing neonatology colleagues that provide these consultations, my friends and colleagues in Mayo Clinic Center for Digital Health, and my fantastic operations manager, Beth Kriofsky. And with that, I look forward to answering any of your questions. Thank you.